I am an ENT surgeon. I would like to know some of the indications in ENT surgery.
The most common indication now is for transoral surgery for base of the tongue cancers. So if you have a cancer of the oropharynx and of the tonsil, you can, without any incision, place the robot, use flexible instruments and take it out. So you don't need to split the jaw and reconstruct it. I think you can do free flaps with this. I don't think people are there as yet. ENT, your specialty, you might know, is the most rapidly growing, the most interest among surgeons is in the ENT field, trying to figure this out. People are thinking about sleep apnea, voice box surgery using the robot. I don't think many of them are done, but this is the future.
Sir, I had an opportunity to have a closer observation at Pune at Galaxy Care Hospitals in this robotic surgery. May I know what sort of courses you have planned and what is the basic qualification you expect?
Do you mean for the urological program or for the foundation?
Because you have given multidisciplinary approach.
Yes, so multidisciplinary, I would again defer to Dr. Bhandari.
There is a complete cognitive cycle we follow. There are two ways. One is you have to go for regular fellowship programs, and that's the way you have to go to a center and have exams and all. Mostly we are talking of the surgeons who are in practice. And two primary things are required, that you have to have an access to robot, because there is no point in training anybody if you can't really do surgery. And second, the intuitive surgical rightly insists that there should be team of two surgeons being trained at a time, so that they can really reverse their roles as a patient side surgeon and a console surgeon. But there are different levels of training, including on-site mentoring, which we are doing for our.
So one really good way of training, but it would be fairly expensive, is using the dual console. So, we have a dual console in Detroit. It has not really been used for training, but it's a great way of doing it. So essentially, you have two consoles, and two surgeons can sit. One surgeon can override the other surgeon, and you can decide who that surgeon is. But someone who is new can get a feel of the instruments, move them without actually harming the patient. So we are thinking of offering that at Henry Ford West Bloomfield. We have a dual console. We'll probably get another dual console. It is expensive because you've got to come to Michigan, you'll need to get a visa, and you'll need to get hospital privileges and all that. But it's absolutely the best way for someone to get a feel for what the robot is without actually having to do it. You can actually participate in surgery and it will be legal.
I'm a gynecologist, I'm a practicing gynecologist. Like how many, we are people who cannot spend long time for fellowships. So how much should be the duration, minimal duration, so that like we can get trained in?
Yeah, I think until you feel comfortable. So different people will have different paces of doing it, and I don't want to give an arbitrary number. Batch your cases, do them together, you can videotape them and then go over them as a team. And when we started doing it, we had nobody to teach us. Intuitive was focused on open heart surgery, not cancer surgery. The open surgeons hated our guts. They felt that this was entirely irresponsible for a surgeon not to actually scrub in and take the patient. So that's what we did. I put a team together, Dr. Peabody, whom you saw, one of my residents named Ashutosh Tiwari. We had the same nurses, and we would do 5 cases in a week. At the end of the week, nobody was speaking to each other because we were so mad at what we were doing. And the nurses would stop talking to us after 1 case, so that's different. That still goes on after 7,000 cases. So Stacy was telling me that she wished I wouldn't do a patient like I did today, because it might be fun for me, but it wasn't fun for her. So we did that. We had certain ground rules. We'll go over the videotape, and everybody could take pot shots at me and pot shots at each other. Oh, you didn't assist this well. You used the wrong instrument. And then we would say, for the next case, these are the changes we're going to do. And we would try to implement those changes. And if they didn't work, everybody could make a comment. It didn't matter who you were, you could tell me. But ultimately, the responsibility was mine, and I would make the decision, and it wouldn't be a decision by committee. And we did that, and it worked well. A year later, Harvard Business Review came up with an article about how minimally invasive surgery, cardiac surgery, was introduced in New England. And the way they decided to introduce it is one Boston hospital hired a minimally invasive cardiac surgeon from New York. And this was a very experienced surgeon, so they said, you come here and start our cardiac program. Well, of course, when one hospital wanted to start a minimally invasive heart program, the second hospital did, and pretty soon there were 8 hospitals starting the cardiac program. And Harvard business professors decided, we want to see how this happened, and they evaluated these centers 8 years later. They thought for sure that the center with the most experienced surgeon was going to have the most numbers and was going to take off. Instead of that, what they found were the young centers were doing better. This experienced surgeon was sure of himself. He said, I can function without a team. I can do whatever case we want. Whereas the other surgeon said, we don't know what to do. We don't have the experience. So let's pool our resources together. Let's pool our cases together. Let's videotape them, and let's make a decision as a team. And that's exactly what I did, a year or two before. And so this seems to be a good model to do it.
I am a very proud Indian today. The reason is, all of us know, many of us got trained abroad or learned from the Western techniques. And the technology was introduced from the West and we took over. And we are very happy that one of our own colleagues who is born Indian has introduced a technology and trained the entire United States of America, and this has prompted all of us to feel that we have reason to feel happy about it. We are proud of Dr. Mani Menon. Having known him for more than 30 years, I have known Dr. Mani Menon, his persuasion, not only his persuasion, the way in which he helps the colleagues, the way in which he trains the youngsters, and the extent of research that he has done. This is all that brought him as the youngest Indian, or youngest probably even among the Americans, to become the chairman at the early age of 35. It's not a small thing indeed. The Americans won't recognize unless you have the merit and talent. And having done that, this 2000 to 2010 is a real discovery. This is an epoch-making discovery which is going to take us for the future. When they were all talking about robotic, I am hearing and seeing also robotic work from yesterday and today. We all thought robotic is a high sophisticated technology which may not be applied in day-to-day practice, particularly prostates. See, I have been professor for nearly 30, 40 years. And what is the reason why we did not do the prostatectomies, radical prostatectomies? We always go under the excuse that we don't see early cases. It is true to some extent. The technology of imaging was not there those days. We did not recognize early cases. And having recognized, we did not have anything to offer. And if at all, a few centers were doing open radical prostatectomies. Then came the laparoscopy. We got excited. And now, at my age, I feel I could have continued to work. This is a great change. You are not served not only urology, you have served the entire human being.
Well,
and more than anything else, the patient care. Ultimately, the patient is the satisfied man. And this is the greatest development that he has brought to us. And I am sure it is going to inspire many of the youngsters to take up to robotic surgery. Thank you, Doctor.
Thank you.